We're live in 5, 4, 3, 2, 1.
Hello, everybody. How are you? So we are finally here. Good morning to a lot of people in the Americas. Good evening to a lot of friends of mine in India. And it's a pleasure to have you all here. This is the 10th Shoulder Planet and OrthoTV webinar in which we are discussing something that we all love to talk about, which is biceps pathology. As you all know, I am Dr. Sergio Rowinski from Shoulder Planet, here from the city of São Paulo in Brazil. And today we have a very special crew on the spaceship. I'm very happy for that. And it's a pleasure to me to introduce to all of you guys in many countries all around the world, such a special team. So who are with us here in this wonderful event today? So we have people from Argentina, we have people from United States, and we have people from, obviously, India. So I'm going to start with the Americas. We have from United States, Dr. Anand Murthi, our good friend, and he is a very talented shoulder surgeon from United States, and he's the chief of the shoulder team on Georgetown University. And he's going to talk about good things about biceps pathology and biceps surgical options and why and how to do this. From Buenos Aires, Argentina, my good friend who is traveling with me for more than 1 year now, Dr. Daniel Moya, who, as we all know, was the president of International Congress of Shoulder and Elbow Surgery 2 years ago in Buenos Aires, and a big shoulder educator all around the world, and developing a strong educational work in the last many years. And from India, two good friends of mine who finally I could bring them and put them here with me. Dr. Rajkumar Amaravati, my good friend, we have been together sometimes in India, in Bangalore. He works in St. John's University, and he's a very skilled arthroscopic surgeon. And Dr. Swarnendu Samanta from, in Brazil, we say Calcutta, and in India, Kolkata, and who has a very big background, and he knows a lot of stuff. He's a wonderful surgeon, and he's gonna talk a lot about the physiopathology of biceps problems, especially in the throwing shoulder, which is a very big challenge for all of us in our daily practice. So having said that, as I always like to do, as we have many people from many countries seeing us, I would just like all of you guys just to say hello to the audience, because they love when they interact with us. And Dr. Anand, thank you for being here, my friend, and just say hello to all of the people waiting weeks to see you.
Well, I want to thank Sergio very much for inviting me. This is such a privilege to do this, and I believe we're bringing the planet closer together, and so I look forward to our lectures today. Thank you. Hello. Good morning, good afternoon, good night.
Lovely. Thank you, sir. Swarnendu.
Yes. So
good to see you, sir.
Yeah, this is we are in the shoulder planet. So we are in the shoulder planet with the guidance of my dear friend Sergio. This whole world, if we think about the planet, all the orthopedic colleagues in the planet, we are coming together through the net. So I welcome you all. It's good morning, good afternoon, good evening, and really we'll enjoy next 2 hours with the leadership of Sergio and our senior colleague, Dr. Moya. Thank you.
Sure. Rajkumar, good to see you, my friend.
Good to see you all, and I bring greetings to you from the city of Bangalore and my college, St. John's Medical College, Bangalore, where I work. And it's a pleasure to share the screen and knowledge with all my erstwhile colleagues here. And I hope the interaction with the colleagues as well as the viewers would be enthralling and educative for all of us. Looking forward to talk to all of you guys. Thank you.
That's going to be a lovely discussion. And Dr. Daniel, as we all know, he was the president of the International Congress in 2019, but he works every day in many things, and it's a pleasure to have him with me. ¿Cómo estás? Bien, mi amigo, bien.
Thank you. Muy bien. Thank you very much. I think we have a great panel and a very interesting topic today. So I am expecting a lot of controversies.
Fantastic. So see, we are going to start, friends, just for the audience to understand. We are going to start with Dr. Anand. Then we will do an interesting discussion. Dr. Swarnendu, Dr. Rajkumar, we have no rush here. I would just remind all of the panelists to speak slowly, as we have many people from many countries with very different accents. Okay, Dr. Anand, you can start. The microphone is yours, my friend.
Great. Can everyone see this?
Yeah.
Excellent.
Yes.
Well, thank you once again, Sergio. Let me get started. You know, it's interesting when you asked me to give this talk. The very first shoulder publication that I did many years, it's almost 21 years ago, was with one of my mentors, Dr. Advisor, on the incidence of pathologic changes. And we showed that, even what you see arthroscopically may not be the entirety of the disease, as the long head of the biceps can be seen very commonly in cuff disease and arthritis. So some of my outline today, we're going to talk a little about anatomy, diagnosis, pathology, and then obviously everyone wants to hear about treatment options. So for me in 21, who gets a biceps tenodesis, I agree with Bolo and a lot of his thoughts on the topic that significant fraying, hourglass deformities, instability, degenerative slap tears in older patients, and tenotomies in the large irreparable cuff. It usually takes one of the big pain generators out of the shoulder. Some of the anatomy that's important is that there's both an intra and extra-articular portion. We know that it attaches to the superior labrum. One of the things we teach our trainees is that it's evolutionary in quadrupeds to bipeds, that in the upright posture, when you rotate the humerus, which you don't have to when you're a quadruped, you might have poor mechanics of the long head of the biceps. The stabilizers to the long head, the interval and the anterior and posterior pulley, which can be damaged during rotator cuff tearings, especially the subscap and the supra, can lead to damage, pathology, and instability to the long head. What does it do? My mentor, Dr. Advisor and Ken Yamaguchi, they did an EMG study that showed there's actually no long head biceps activity during shoulder movement, and perhaps we'll have some discussion and disagreement on that. Is it a stabilizer? Probably very small in anterior instability in that cocking phase. And so perhaps this is just a vestigial structure that's meant to cause pain. Maybe it's like the appendix of the shoulder, and that the function may be limited in the upright posture because our scapula is not in line. So how do we diagnose it? It can be a very difficult diagnosis, and perhaps one of exclusion. It's relatively easy to diagnose a rotator cuff tear, but just associated or singular biceps problems may be very different. I really think that pain and palpation are probably the most common and sensitive tests for myself. It may radiate down the arm. I think sometimes we'll have crepitus with rotation and pain with limited motion, but that's often commonly seen with cuff disease and arthrosis as well. It's not as obvious as you can see in this patient, but if you have the patient keep their arm on their thigh, usually the biceps tendon is directly anterior, and you can palpate, and especially if it's swollen or you have groove pain or groove symptoms, you can see it palpated in the front. These other tests are very non-specific. We put them into the algorithm. It's testing for biceps disease or superior labrum pathology, but once again, they're not very specific. Imaging, usually x-rays and MRIs and CAT scans. We're looking for associated pathology, and we'll see biceps edema and fluid. Ultrasound is very good for injections. It's a dynamic test, operator dependent. If you really are focusing on the biceps, an MRI arthrogram may be beneficial. But it's interesting, when I was training with Dr. Advisor, he used an arthrogram all the time, and it actually gives you a really great view of the biceps groove. Arthroscopy obviously is the gold standard. It's dynamic. You can palpate the tendon, you can pull it into the joint and get a good assessment of the outside pathology as well. What's our pathology that we're looking for? We're looking for intrinsic, extrinsic, impending pathology. These are actually some slides from open surgery. You can see the significant damage in the bicep tendon. Often leads to delamination and rupture. This hourglass deformity can actually become stuck at the transverse humeral ligament and cause actually the inability to raise the arm. Rupture, people will come in and say they have this horrible pain, ecchymosis, develop this Popeye sign, and usually after a few weeks, obviously the Popeye sign will stay. In thin people, you can notice it, but the majority actually their pain will resolve. Instability, while rare, is often seen with upper subscapularis border tears, and usually it's treated concomitantly with the subscapularis pathology. And we actually often see this with rotator cuff disease, and we usually take the biceps, as Sergio said, we kill the biceps and tenodesis it when it's associated with any type of rotator cuff problem, as we're looking to keep any type of pain generator out of the shoulder. Impending pathology, cuff disease, cuff repair. We routinely tenodese or tenotomize the biceps tendon long head if it's involved. If it's pristine and they have no pre-op symptoms, we leave it alone. Inflammatory lesions, patients with inflammatory disease, rheumatoid, etc., will often have this along with their arthrosis or their inflammatory cartilage problem. And it's both a macroscopic as well as a microscopic problem, as we've seen on histopathology. So let's get to the fun part, talking about surgical treatment once we've diagnosed it. Limited debridement or tenolysis. I agree with Dr. Arciero in that for me, it's either a bad biceps or a good biceps. I'm either going to leave it alone completely, or I'm going to do some type of treatment for whether that's a tenotomy or a tenodesis. I think just debriding this degenerative tissue likely will not give you a good result. Biceps relocation, I think this was actually in favor in the 70s, 80s, and 90s. And both Dr. Walsh and when I was a fellow with Dr. Biliani, we presented on our relocation data or replacing an unstable or degenerative biceps, reconstructing the sheath, and very poor results, usually leading to second revision surgery. Tenotomy, very commonly done in the public. If it works well, it works well. The problem is if it doesn't work well, it becomes a cosmetic cramping type of problem. We'll often, in patients with larger arms, lower demand, release the biceps tendon with a slip or a T-shaped portion of the superior labrum, and it will act as an autotenodesis in the transverse humeral ligament. The problem often is this cramping Popeye deformity. Studies show that little clinical difference is seen, and only 40% notice the deformity. But if you have a thin patient, often women who have a large deformity like this, they're not very happy with their outcome, even if they have pain relief. And this is the issue we see is cramping and fatigability, especially in laborers and people working overhead or doing a lot of heavy machinery, plumbers, electricians. So for me, if I'm going to deal with the biceps tendon, I feel it's a relatively simple tenodesis. So we discussed above or below the groove, and I'll give you some of my thoughts. Proximal biceps tenodesis, usually up in the groove, right at the top of the biceps groove, and to the supraspinatus. The goal is to get scarring to the bicipital groove, and it's an onlay technique. It's relatively easy to tension. You can dial it in, and I'll show you a technique for that. And I used to ask my colleagues who do this most often, how does it eliminate groove pain? And the theory is that it prevents this pistoning and motion in the groove, and that will resolve the inflammatory inflammation. So we do this in a traditional beach chair position. The pit technique is one of the simple techniques, which is essentially percutaneously placing sutures through the rotator cuff, the interval, and then tying them in the subacromial space after you've cleaned out the bursa. Very cheap, usually for older patients. You have to do a bipolar tenotomy at the end, which is releasing it laterally and medially and taking out the intra-articular portion. Relatively simple to do. You use Prolene or a non-absorbable suture, but not great fixation. Suture anchor fixation was then used, whatever type of anchor you want to do. It's difficult, once again, to get your optimal length as you end up shortening the tendon. And we'll often use just a anchor or self-drilling anchor into the repair when we're doing a rotator cuff from the subacromial space. This technique, we're always looking for cost savings, now that in the US we do majority of our surgeries at surgery centers, and cost savings is very important. This loop bicep tenotomy is similar to that auto T-shaped tenodesis that I spoke of earlier. Essentially, you're releasing the bicep tendon at the superior glenoid and then pulling it through itself to create this bulbous type of long head of biceps that will then capture autotenodese in the transverse humeral ligament. So relatively inexpensive, relatively quick to perform. This is the loop and tack procedure. This is relatively real time. One of our residents, this is a right shoulder. You bring a suture in of any type through your anterior portal. The key is to get this suture near the exit of the biceps tendon, not medially towards the glenoid, but laterally towards the exit of your biceps tendon, because we're going to loop it and then tack it right at the exit outside down the bicipital groove. So after you've passed your single loop, for additional fixation, you're going to pass a type of bird beak device or a sharp device through the tendon, grasp your suture again, and essentially you're making a one-way cinch with an extension of the suture material. So this procedure is relatively efficient to do, especially if you want to do arthroscopic or all arthroscopic surgery. Now you've double cinched the suture. Outside, you're going to attach it to a push lock or a self-drilling type of anchor. You're going to detach the biceps at the superior labrum. But now that you have fixation and you can hold it, you're now going to put it through whatever anchor type device that you like to use up into the groove. We use these types of screw-in type of anchors with good fixation. And you can see when you're completed, you have nice compression. It's an on-lay technique. And when you move the arm and you remove the sutures, you can see it's relatively rigid fixation. And the goal obviously is to hopefully get that to scar in. And I use that for relatively low demand patients. And sometimes we find incidental bicep findings. This is my gold standard. I think this treats all the pathology as well as gets your bicep tendon out of the groove, rigid fixation that allows for early motion and removing all the pathology. And this goes back to my very initial study in 2000 of treating the distal pathology in the bicep tendon. I think it's very helpful for patients who have this bicep chondromalacia. You'll see patients who've actually put a groove into their humeral head, and they'll have actually loose bodies and synovium that go down the sheath. And I don't think a proximal tenodesis up into the joint will be beneficial. This is a right shoulder. We can make the incision really relatively small in the axilla. And the goal is to get through this brachial fascia, which can be relatively thick. And then you can use a combination of Army Navies or Homans to get the pectoralis north and the short head south. And once you do that, you're going to be looking at the biceps groove. And so once you're looking at the biceps groove, the key here is to stay lateral to the short head, so you're away from the musculocutaneous nerve and median nerve. This is another video we're taking through a head cam. You can actually mark where the bicep tendon lays in the groove underneath the pectoralis, so you know exactly how to get your optimal length. And that may be difficult if it's retracted once you tenotomize it, but usually it just sits there and you actually have to pull it out. Here we're just using a standard, this is a inlay type of procedure. You can see that we can dunk it, and it's a bicortical fixation with an interference screw as well, kind of a double backup type of procedure. So you can drill a small hole that's bicortical, and then you follow it with the diameter of the tendon that you've created. The risks here are obviously have been some noted case reports on proximal humerus fracture. You have to make sure you're center on the humerus, but you can see it nicely dunks this and makes this an intramedullary fixation type of procedure. And you can follow that up and back that up with a screw. Once again, looking for cost savings, right shoulder. Here we're using a Holman to retract the pectoralis, bring the bicep tendon into the field. We resect about 2 centimeters at the muscle tendon junction. small non-absorbable suture. And then we do a simple keyhole type of technique from the early 1900s. We use a passing wire to dunk this tendon into a small drill socket, and then the passing wire brings those sutures through on either side of the socket, and you're able to dunk it in. And this is a relatively quick, easy to do procedure. Looks similar to our fancy interference screw and button, and costs about $100. So I know a lot of countries and surgical centers are looking for cost savings. It's a relatively quick way to do it. When I rehab with the subpec tenodesis, I allow early motion. We want to get external rotation, especially they can get some stiffness and external rotation. And we avoid bicep strengthening for about 6 weeks, but the fixation and revision rate is very low. So for me, my thoughts are subpectoral biceps for laborers, isolated biceps disease, workers' compensation, any type of revision shoulder surgery, including the cuff, gets the bicep tenodesis in a subpectoralis fashion. And usually arthroscopic is limited to incorporating it into a degenerative cuff repair and incidental finding in low demand patients. Thank you very much.
Lovely, lovely, lovely. Anand, so you stop sharing your screen. Well, you see, beautiful presentation. And I would like I wish we had only 10 hours to discuss your presentation. Unfortunately, we don't have it. But I have a lot of interesting things to ask. We have time, and I think that many ideas can be passed to the juniors. I'm always thinking about the juniors in India and all around the world. So first of all, I would like to thank you for making, Anand, a photography of my life in the last 16 years, because you made a photo of exactly what is my life, because I am scared about how my life is similar to yours regarding this and how my thinking is similar to yours, because I do basically the same stuff with the same rationales. But some things that I would like to highlight, and then I'm just gonna highlight 2 ideas and start discussion, because I think that we have some very important things to discuss about diagnosis, okay, and about one aspect of the surgical technique. So first of all, I would like to highlight that I fully agree with you that the biceps is a vestige. The biceps, I mean the intra-articular portion of the long head of the biceps, is a vestigial structure which has 5 functions in the shoulder: pain, trouble, and trouble. If we think about phylogenetics, and if we go to the dictionary, if we open the dictionary, what's the definition of vestigial? Vestigial is a structure that had importance in the past, but it doesn't have importance in the present, okay? This is not what I think. This is written in the dictionary. If we think we have another vestigial organs in the human body, and I'm just gonna mention to you 2. One is the vermiformix appendix, which has only one function in the body, which is to do appendicitis and give money to the gastrosurgeon. Yeah. Right. The other one, we have many others, is the wisdom teeth. The wisdom teeth, they have no function, but they can give you problems. And the function is to give problems to the patient and money to the dentist. We say this in Brazil, and so on. So I see the intra-articular portion of the long head of the biceps in the same way. It's not a stabilizer, as you have mentioned. It doesn't move concerning all of the rotator cuff motion. So it's not stabilizing anything. It's not giving you significant motion, but I'm not gonna get into that, but we had problems when Mother Nature made the mammals go from quadrupeds like dogs and horses to human beings, which are bipeds. Nature had to do an external rotation of the proximal part of the humerus. And then that very, I would say, sad angle that the biceps does from extra-articular to intra-articular. And this is what we like to call the killer angle or the problematic angle. So, so in this sense, I fully agree that it's all or none. Or you leave it or you kill it. I don't see any reasons in just making I would say, debridement or shaving somehow. It's all or nothing. I fully agree. But one thing that I would like to discuss before some stuff on surgical issues is this. You know, it's not easy, I would say, to define, I would say, anatomical problems of the biceps on the MRI. It's a limitation, is a limitation of the method. So having said that, the physical examination is very important. So palpation of the bicipital groove is very important, especially in a little bit of external rotation. I fully agree that the pain from the long head of the biceps irradiates anterolaterally, especially in the two proximal thirds. And the thing is, there is a huge relation in between long head of the biceps lesions and subscap tears. So we have to think about not only posterior-superior tears, but when we think about anterior-superior tears, it's very correlated, the subscap problems and biceps problems. In this sense, a very, very well done arthroscopic, I would say, analysis of the subscap must also be done, because many times there are hidden lesions that if you don't, and if you don't search for them, you will miss out. This is very important. So I would love to listen from you guys. What are your concerns in not missing a subscap tear associated with a biceps lesion? Because it's related in literature that many people don't see it. And even with a double row in the supra, your final clinical results will be very bad. This is something very important for us to discuss. Dr. Swarnendu, you start, sir.
Yeah, but the thing is that the question is very good, I think, Sergio, because the juniors, those who are listening to the biceps, because we are discussing about the unsolved issues. And if you see the biceps is, this line is extremely important. If you see the biceps is not in its pulley, in its place, and is medially displaced.
Sure.
And it is frayed at the junction where if you put your probe and pull down your biceps in the joint, if you said something is frayed, you must suspect that something has happened to the medial pulley. And this medial pulley is done by your upper subscap. So you have to, you have your eyebrows should now frown, and you should search that I'm not missing the subscap tear at the top. Because if the biceps, the two lines is important. If your biceps is subluxated or dislocated, or your medial pulley is gone, and there is fraying in the intra-articular part, when the groove part, when you drag down this thing, then you must suspect and be 100% sure that you are not missing the upper subscap tear.
And do you agree, Dr. Rajkumar, that all of this intra-operative analysis of the subscap is dynamical, is not statical? You have to move the arm internally, externally, and do what Burkhardt says, the lever push. So you do some elevation. And this is magic. When you do 20 degrees of elevation, not at the side, but a little bit up, you can see a lot of things in a different way. That would be a big tip that I would give to juniors, dynamic analysis and with a lever push. Any comments on that? This is a very practical tip that makes all of the difference. Dr. Rajkumar.
I must congratulate Dr. Anand for his wonderful presentation here. And I also would agree with all the thought process that you are discussing over the last 5 minutes. I must say that the clinical examination should take the first row in diagnosing a biceps pathology. Although supplementation by investigation methods like MRI and arthro-MRI, arthro-CT will help, the final diagnosis of a biceps pathology is by arthroscopy.
Sure, fantastic. Sure.
If you have seen the clinical examination, the point described by Mazoka is a good point to examine the biceps here.
Yeah.
That is called as the Mazoka's point. And you showed very rightly that you need to palpate in external rotation. And that is a point to examine, that is number one. There are various clinical tests described in the book for biceps pathology.
Sure.
Not one is correct. But yes,
Sure.
you need to go through the protocol. And shortly we'll be coming out with the test for biceps or the slap pathologies in the shoulder, which we'll be publishing it shortly. We are into the clinical research of that. And it will be a wonderful thing to see how we can do examination of instability because of biceps pathology.
Yeah, you know,
Having said that, I saw
No.
Dr. Anand bringing in the biceps in the joint. That biceps was really very innocuous to look at in the beginning. But when we see that he takes the probe and pulls it down into the joint,
yes,
that biceps cannot be saved. That is
Definitely.
when you have to plan and say, okay, I have to kill the biceps. That is point number one. Number two, where you're discussing with Samanta, where the biceps, slides or, comes into the superior part of the subscap. Yes, that will happen when there is a tear of the restraints in the groove. Not always biceps will tear the subscap, but there are situations wherein biceps will come and tear the upper part of the subscap. That is when the test that you described, the liver push, also described by Patrick Dinard, I guess,
Yes.
will definitely help. And that is how you have to examine the biceps in toto so that you can plan an optimum outcome for that patient. Thank you.
Yes, but yes, sir, definitely. But what I was mentioning is to do a lever push maneuver intraoperatively. It's a game changer. It's a game changer to me. And one thing that we must reinforce to the juniors is that not only the subscap intraoperative analysis is dynamical, but the long head is dynamical too. This is what Dr. Anand was doing, to put the intra-articular portion inside the joint. I do this all of the time, and I think it's much better to do this maneuver with the arm in abduction and external rotation. It's very difficult to put the biceps inside the joint with the arm at the side. So I keep my assistant at that 10-second part of the surgery always like this. This is a game changer to me. And I think that having said that, now I'm gonna say something very interesting. Almost everybody does shoulder arthroscopy here in my country in beach chair. In the United States, I guess a lot of people in beach chair. But in India, the vast majority of the people do in lateral decubitus. I have been in India many times and I saw that. So in my opinion, this is for the Indian juniors. How do you manage to put the long head of the biceps intraoperatively in lateral decubitus? Because of the traction, it's not easy to do all of these passive maneuvers. Any tips for that? This is for the Indian guys, but the question is very good, Dr. Swarnendu.
Yes, I had the opportunity to work for some time with the big boss, Steve Barker. So I'm honored to work with him for some time because I know that he is very fond of doing this liver push maneuver. And whenever he sees this, that something is there in pathology in the biceps, he will definitely do this liver push. It is a very simple mechanism. Just put one assistant, he will be pushing one arm at the elbow, other at the front of the shoulder, and you will see the front of the shoulder beautifully, even from the backside with your viewing portal. It's very beautiful maneuver. Okay. The second thing is that in the lateral, we don't put the fixed traction in lateral, like you're fixing it with something. So you can still even I have seen Dr. Steve Barker doing your all shoulder in lateral. So he was doing your all subscap repair in lateral position. So if you just see the trick, how you can pull this thing, how you can even pull the arm in external rotation and abduction to see the biceps and the front of the your lesser tuberosity and the subscapularis insertion. This can be done even in the lateral, not in the B chair only. So you have to learn the trick how to see in lateral.
Yeah, but does any nurse has to lift the weights in order for to relieve the traction? Or not
at all, because we don't put any weight, like it is not more than 7.5 to 10 pounds of weight. That is nothing. It is just for this position of the arm. It is not like any sort of traction is given. It is just for keeping the arm in position in rotator cuff, and in all this, the weight is very minimal. You don't remember, okay. This is for the juniors, that this weight is not for putting the traction to your limb. It is just helping to keep the arm in certain position so that your one assistant is not being tired during the operation. It is not anyway meant for any traction.
Lovely. And I have a question to Dr. Daniel, because he has a lot of experience in arthroscopy and he has a gigantic experience still in open rotator cuff repair. So, and I know that many Indians, they don't do arthroscopy and they do cuffs in open fashion. You don't have to feel ashamed for that. We have to know our limits. But the thing is that when we think about open repair of cuff lesions, it's difficult to see the subscap. It's written in all books, the hidden lesions. So for those in India who are doing cuffs open, how can you advise them, Dr. Daniel, about searching for a subscap tear, which is very difficult in open fashion? This is a nice question.
Thank you, Sergio. First, I would like to make clear that to choose open surgery in some cases is not a matter of limit, it's a matter of choice.
Okay.
And so, you know, it has not been demonstrated yet that there are clear significant advantages in rotator cuff repair. Let's be clear with that.
Yeah.
So if not, I ask you to show me a study with high level of evidence that can show that, and you will not find that as far as I know. So making this clear, I would like to say that I find many controversial issues with this, and I can speak with a point of view from 30 years. And yes. I have seen that, you know, it's like there are seasons. There are seasons in which we consider that the long head of the biceps is vestigial, and there are seasons in which some papers appear saying, no, it has a function. Now we all agree in that it is vestigial, but we don't know in the future. That's why I think we should be very, you know, sure when we indicate the tenotomy. And in that way, I think that I don't want, well, I prefer not to go to surgery with doubts. At least I try to have the less doubts I can. We used 30 years ago to find many surprises in our surgeries. We didn't have MRIs, shoulder MRIs. I began when there were not shoulder MRIs. We were going to treat rotator cuff tear with an arthrography. So we used to find many surprises. And I think that a tool that is very important, and we have not mentioned yet, is ultrasound. Because MRI is a very good diagnostic tool when you have a locked instability of the biceps. You know, when there is a medial luxation of dislocation of the biceps, or when there is medial subluxation of the biceps, but there are also dynamic instabilities.
Sure.
There are dynamic dislocations. Generally, dynamic dislocations can be evaluated with physical examination, and they appear in older people. But there is a condition, there is an injury that is the subluxation, the dynamic subluxation of the biceps, especially in young athletes, that it is very difficult to evaluate with physical examination. And in that way, for me, it's very important to have a reliable radiologist and to have it is a dynamic problem. We need a dynamic evaluation, and with an ultrasound, you can go to surgery knowing if there is an instability, a very subtle instability of the long head of the biceps or not. So I think that we have a lot of tools now to go to surgery with a very clear idea of what is going on. Of course, always an arthroscopic evaluation before taking decisions is the last diagnostic step. But we must know that there are some other steps that we can use and have a lot of information before going to surgery.
Yeah, you know, this is very important because the thing is, we can, from a clinical, I'm going to mention something very clear, and I would like to listen Dr. Anand's experience in the United States. It's very, I would say, it's very difficult to figure out a biceps instability in the poly from a clinical point of view. You can make a suspicion in your mind, but even with physical examination, pain is there, some inflammation of the poly is there, but we cannot dare to say that there is instability by a physical examination. This is to the best of my understanding. And having said that, the MRI doesn't give us the information. What we see in the MRI is indirect signs of biceps involvement. Edema in the poly, maybe I would say a small tear in the transverse ligament in between the tuberosities and or some fraying in the subscap. But the MRI fails a lot in showing upper third articular subscap tears. This is written in many articles. In that sense, dynamic analysis of the biceps with ultrasound before surgery would be, I would say, a quite good tool, as Dr. Daniel was mentioning, but I don't have this in the end. So we don't have to forget, as Dr. Daniel said, the diagnostic role of arthroscopy, yeah, is not finding, as we say in Brazil, hair in eggs. It's not that. It's trying to enhance your diagnostic tools before you start fixing things. But having said that, Dr. Anand, in the United States, do you use ultrasound, I would say, to enhance your I would say, diagnosis in the office, or it doesn't happen on your practice? You know, this is the hit of the moment, we know now, but I would like to know your experience because I have zero.
With regards to the bicep instability, I think you can sometimes feel it on exam if it's snapping across when you rotate. It's pretty rare. Okay. We have special ultrasonographers who can do dynamic ultrasound, especially for sheath injection, so corticosteroid or whatever biologic injection. So those are relatively easy to see on ultrasound. You can actually see it really nicely, a swollen bicep. And then you can rotate the arm and see the biceps kind of sublux if there's a torn transverse humeral ligament. So ultrasound is really useful, especially for injections. But I think, once again, if you've got to the point where they feel conservative, you're going to be doing an arthroscopy anyway to be able to pull it in.
Yes, and even because we cannot forget, and Dr. Daniel will agree 100% with me, that when we have partial cuff tears with signs of biceps involvement, many times there is a huge space for non-operative management, unquestionably, with physiotherapy and or corticoid injections and or these newer things like hyaluronic acid and these biological things. So we don't have to rush on going to surgery. This is a message that must be quite clear for all of us. But before we move to Dr. Swarnendu lecture, I have another thing to discuss, because this has been a doubt in my mind for 10 years, and this is a good chance to discuss this, to enlighten
10 years, that's a long time.
Okay.
10 years is a long time to have doubt.
Yeah, no, I have ideas, but I don't have the definitive answer, which is the existence of polypain, pain. So the only way in my mind to kill all of the problem is to put the biceps on a subpec tenodesis, yeah? Because as you mentioned, when you said, Anand, you take out all of this synovial involvement, you are talking about polypain or poly involvement. So the thing is, whenever I have, I would say, a younger man, he goes to sports and he goes to the gym and he swims, I don't give it a chance to do a biceps tenodesis intra-articular. First, because if I have polypain for the rest of my life, that will be a very complex problems to manage. And if I do a subpec tenodesis, I'm gonna fix this forever. And second, because if I have a strong user of the long head of the biceps, he goes to the gym, we have many guys like this here in Brazil. I always fear that maybe I may lose my tenodesis if I do it with an anchor on the lesser tuberosity. Right. So, but what I've been doing in Brazil because of costs, is the subpectorale tenodesis mini open like you, but what I do is simply 2 holes, and I pass through the 2 holes, and I do a tenodesis in the biceps itself. I don't do in the same level to avoid a stress fracture. Right. So one up, one down, and I pass the biceps, and it costs 1 nylon suture or 1 ethibond suture. And my results are outstanding. So the thing is, I think that this must be highlighted because I have operated many shoulders in India and I know the problems with the costs. So having said that, that would be an option that I do here in Brazil. And I think that the cost benefit is something quite nice. But anyway, Dr. Rajkumar, you are gonna make a presentation on that. But before we move, do you like doing such a subpec tenodesis with 0 implants and only 2 holes? It works so beautifully to me. It's so cheap. I think that if we think about the Indian scenario, it would fit. What do you think about that, Dr. Swarnendu and Dr. Rajkumar?
Yeah, I know this, what my dear friend, Dr. Rajkumar is doing for this keyhole. Biceps tenodesis, that is excellent. And I think if you talk of the cost issue, it is just revolutionary idea of doing this thing because it doesn't need anything. Just you have to do. When I think Dr. Rajkumar will be presenting his talk, and then we'll all understand this is very, very simple technique. It is known as the keyhole technique. It is just like a lock and key sort of mechanism. Sure. So it locks there. So it's it is very cost effective. And if you talk of the cost, both in Brazil and in the Indonesia, I think that is too good a technique.
Yes. These young guys don't want that. These young guys like all those fancy tools, though.
But this is important for us to understand that, we know that the economical background in terms of health assistance in the United States is completely different from India. In my office, in my private patients with health insurance, I can have basically whatever I want. But in my public hospital, it's another story. So we have to discuss these things because it fits the Indian scenario too much. So having said that, Dr. Swarnendu, now I'm going to ask you to talk about your beautiful presentation on physiopathology of biceps, especially in the throwing shoulder. And I again highlight all of the presenters to speak slowly for everybody to understand in all of the countries that are watching us. You can start, sir.
Is it coming, Sergio?
Yes, sure, yes.
So, okay. So I think,
sir, you can start putting your presentation bigger, I guess.
No, I'm just making it a full screen. Okay.
Oh yes, yes.
So is it coming now? I think.
Now, yes, yes, you can start, sir.
So I think it's a great honor. My dear friend Sergio has talked to us, and he has given me the opportunity of interacting with you people in the shoulder planet. I'm in a different part of the globe. I'm from the city of Joy, Calcutta, India, and we're interacting with friends across the globe with dear friend Sergio and Dr. Anand Murthi and the senior colleague, Dr. Daniel Moya, and my dear friend Rajkumar, and those who are listening throughout the world. Good morning, good afternoon, and good evening. So today, Sergio has given me the task of this not the surgical part. I am going to go give some idea about how the pathophysiology and how the biceps is doing inside the joint. And I think my dear friend Sergio is there are two schools of thought. One is the biceps killer, one is the biceps savior. The problem is that when the biceps is in the throwing athlete, then it's a problem because you cannot kill those biceps. Because you have to give them the best possible function because they are going to play again. And you see that if you see the kinetic chain of this throwing mechanism, it is a real complex. Like it's wind up, the early cocking, late cocking, acceleration, deceleration, and follow through. You all know all these stages, okay? But the thing is that if you consider this kinetic chain, the force is generated from the ground. The leg has to be stuck on the ground and the trunk, and then this force goes in the funnel, and the force regulator is the shoulder, and the arm is going to delivery. Ultimately, the arm is going to deliver that force. So the key elements in this chain is the body rotation, the timing, the scapular position, and also the balance between the mobility and the stability. And this is known because we are all fighting between the mobility and stability. That's why it is known as the thrower's paradox. And you all know in the muscles which are going to be active in the cocking phase, like your early cocking, the deltoid, the late cocking is the supra, infra, and the teres. And you know, and the acceleration phase, your triceps, the pec major, the delta dorsi, and the serratus anterior, and also in the deceleration, which is the most harmful phase for your throwing athlete. Because in this phase, if it is not proper, they are going to injure the biceps. So if you are dealing with some problem, if the guy is not having the 100% during his activity in this throwing athlete group, the racket sports, then you have to be very cautious. You are not going to miss the biceps. Because if we talk of the pathomechanics, you know it can happen of the acute trauma, like followed the outrage act. The main problem is the chronic trauma, what the throwing athletes, they are going to see and experience. There are a lot many theories, like it can be like traction injury or the peel back mechanism. You know, it can be like compression theory is there. And also there is a traction mechanism because of the repeated use of the arm, the supraglenoid part where the long head of the biceps is attached, during the deceleration phase of the throwing, this part is peeled off, okay? And this peel back mechanism, you know that when you go into the hyper abduction and external rotation, if you see the picture, the whole biceps is rotated backwards. So it peels off from the 12 o'clock and also from the backside. And in the late cocking phase, if you see this picture in the right down corner, if you see the mouse, you see the biceps is located here. But when you are going to go for the early deceleration phase, your biceps is moving from one location to the other. So it is basically biceps is very, very dynamic from your all phases of your throwing. So in the late cocking and the early deceleration, the biceps is moving from one location to the other. So it is not only one mechanism. The bicep, the slap lesion, which is going to happen, there are like traction theory, the peel back, the micro instability, all these overlap to create the biceps pathology in the throwing athlete. So it is a real complex issue. And the problem is that you cannot kill those biceps. Okay, even if you go to fix those biceps subpectorally, your subpectoral, then it is also a problem. So you have to be very, very cautious in understanding the pathology of this, the intra-articular part of the biceps in the throwing athletes. Okay, and the main problem is the capsular contracture. Even these guys, when they go for the hyperabduction and the external rotation, they lose some part of the internal rotation. That we know the the grid, you know, they lose the terminal part of the internal rotation, and they, because to gain this extra degrees of abduction and external rotation, they are doing this. And what is the mechanism behind? With when they do this, there is a posterior capsular contracture. So head is supposed to move posterior-inferiorly in the late cocking phase if your shoulder is normal. But if there is a posterior capsular contracture, the head is not moving posterior-inferiorly. So now the head is moving posterior-superiorly to give the external rotation and the abduction. The mechanism, the biomechanics change during your throwing motion. So head is moving posteriorly and superiorly. So if there is complete slap, there is micro instability in the shoulder. And now you see, if there is a complete slap tear, there is 6 millimeter of increased anterior glenohumeral translation. This line is very, very important. So if you diagnose the slap, there is also the combination of micro instability. So if you are dealing with the elite athlete, then you have to be very cautious that you are dealing with not only with the slap, you are dealing with the loss of internal rotation, terminal internal rotation. There is the biomechanical change with the head is supposed to move in the posterior inferior direction in your terminal abduction external rotation. Now it is moving posterior superiorly. That's why there is a peel back in the posterior superior location, like 7 o'clock to 8 o'clock in the right shoulder. And also, if you see this Andrew study, there in the ball pictures, there is also some partial articular tendon avulsion. So now you see it is becoming more complex. So if in the Snyder study also, if you find there is also the nearly 30% they are having the partial articular tendon tear. Also there is some rotator cuff tears around 20%. And also, as I told you, the classic sort of banker lesion you can find in more than 10% of cases. So now you see, if you just think of the slap tears, which was the term which was given by Steve Snyder, like 1, 2, 3, 4. Now it is now being complex because there is micro instability, there is pasta lesion, and some people, they are having some rotator cuff problem. So if you are dealing with the elite athlete who is going to throw, who is going to swim, who is going to do some racket sports, or who is going to throw the balls, then the problem that you are going. Now the Snyder classification, you all know, 1, 2, 3, 4. This is very simplified way of thinking. But now with the MAFE and all this, now we are having 10 groups of this. This is a big classification for the slap tears now, because it is not only dealing with the 12 o'clock, it is dealing at the front, it is dealing with the backside of your capsular tear. So this is also now extending even into the biceps tendon. So symptomatically, they will be having, not only having the frank pain sort of thing, they will be having some vague fatigue pain around the shoulder. The complex will be clicking, popping and snapping. It's not always there. Then difficulty in sleeping at night and pain, particularly in certain phase of the throwing cycle. So you have to listen to the guy, and you have, if he is telling that I have lost my throwing capability, then you must look very carefully that you are not missing the slap, you are not missing the the subtle change in the glenohumeral translation, which might be the micro instability or even my minimal tear at the front. Okay. And so putting the pulling through in the swimmers, making contact with the ball in the racket sports or releasing the ball in throwing, these three will change because there is biomechanical change in the intra-articular part or the biceps attachment at the supraglenoid tubercle. There are many tests. Believe me, there are many tests for your biceps. But as my friend Dr. Rajkumar was telling, and Dr. Anand was telling, my dear friend, we have all discussed with Sergio also, there is no single test which can tell you that this guy is having the slap tear. So we have to be very, very cautious. We have to listen to the history, what the guy is complaining. The speed of the O'Brien will talk of your anterior slap. The Joe can tell you the hint for your posterior slap. But the pre-slap syndrome, what is that? This is new terminology. The tightness of the back of the shoulder, the instability, inability to get loose because they have to be loose in their external rotation and abduction. This shoulder is now at risk. And now I will request all my juniors, please see the internal rotation deficit and compare with the other side. Otherwise, you might miss the micro instability. Then there is a problem. And never forget to look for the scapular stability. The sixth scapula, if the scapula is not in proper mode, you can, because all the pathology can start from the sixth scapular syndrome. So the GIRD that you have to test from the normal side. And please do next time onwards, if you see some shoulder pathology in the young people, the scapular assisted test and the scapular retraction. And hardly this will 10 second time, but you will never miss the scapular dyskinesia or if it is starting from the scapula. Because these sort of symptoms, if you stabilize, if you are very good rehab team with you, if you rehab the scapula, more than 50% of the throwing athletes, they will recover. It doesn't need surgery. And if you see the correct and incorrect motion, you have to see how they are doing their throwing activity. What is the correct and incorrect movement of your elbow? Because if the elbow is bent, then he is not doing justice to the shoulder. So you know that we can do it. Remember that the MRI we can do with the contrast. But remember, even the small slap tears can be missed in the MRI. We are all discussing, because if you go with your scope inside, probably you will see better, because the groove part, the hidden part, the pulley mechanism, that you cannot see with your MRI. You can do the MRI even in the ABAR position to see how the biceps is moving. And you can also see sometimes your faster lesions over there. So there are many, your sublabral holes and all this. These are the classic signs. But believe me, most of the people, if you diagnose the sixth scapular syndrome, then with your analgesics, proper physio and rehab, you can get back the throwing athlete. And if the motion is correct, because sometimes they are throwing, how they are throwing, if you don't see that, you cannot correct those. We should not jump into the surgery. So conservative always is there. But a young, high demand patient, if there is conservative treatment, then go for the surgery. I am not going to do how we do your like debridement fixes and all this. Suppose you see this slab, probably sometimes we can debride it, but sometimes if you don't probe it, probably you are going to miss something. So once you go inside, then you will see how this is behaving. You see, now I have gone inside. You see, which was seeing like a small slap tear. Now you see, once I have gone inside, how much it has peeled off from the backside. It has also peeled off from the backside. Now you see, once I am clearing the backside, I will be, because you see, when you want to fix the biceps at the 12 o'clock, you have to abrade that part, because you have to recreate the regenerating capability of fixing that biceps. Okay. And now you take care of that part. You take your anchors over there, and always remember that slab. When we started doing the slab, we usually doing the front and back fix. Now people are telling that you have to fix very lightly because you cannot make your slab very, very tight. So if you make the slab very, very tight, this guy will be a very, very unhappy patient. And always remember that the knot should be away from the joint because it's not going to abrade. Now you see, even the front, there is a big tear and the anterior capsule. So I have also put one anchor over there and I have fixed that part of the anterior. So this is not like your classic Snyder 4. It is your Maffei 7. So it is like the posterior tear. It is also there is tear in the front. So you can use all your instruments to see how you can fix not only the supraglenoid part, but you have to fix the anterior part, the posterior part. But remember that don't make the slab very, very tight because if you make it very tight, this guy will be very, very unhappy patient. So remember this, that you don't make the biceps absolutely rigidly fixed. Sometimes if it is bit loose rather, will give him the extra bit of extra rotation and abduction so that he can have the throwing capability. And again, he can go back to the same level of sports. And remember, not only your surgery, your rehab is very, very important. You sling it, you restore the range of motion. Now you have to regain the strength, and at the range of 4 to 6 months, probably if you do the surgery properly, he will go back to the your same level sports. And remember the pre-slap stage, you have to catch those guys. You have to diagnose early so that you can rehab them and never forget to check this capital. So thank you all for your kind and patient hearing. If there is any question from my dear friend Sergio, my senior colleague Moya, we can take those. Thank you very much, Sergio.
Lovely, lovely, sir. Beautiful. You just have to stop sharing your screen, sir. Well, you see, sir, thanks a lot. Beautiful presentation, very nice. I must tell you that I am here to learn a lot of stuff. I reviewed many concepts because I do a lot of shoulder degenerative pathology in the office, but I don't deal with throwers directly. So it was very interesting, and thank you, sir. I would like to highlight some stuff and discuss some interesting things with you guys. The first one is this. When Dr. Swarnendu was talking about chronic trauma, just for the beginners to understand, we are talking about repetitive micro trauma. So they are doing micro trauma all of the time, and they end up in these situations. Another thing is that just for the juniors, to remind the juniors, a prodrome is a beautiful medical terminology from general practice, and I find it beautiful that you are using in orthopedics, which means, again, the definition is symptoms indicating the onset of a disease or an illness. And this is beautiful because what it means, sir, is that we can infer that something is happening and may lead into a slap in the near future. So what you have said, sir, is that we must have a very strong clinical eye on these patients. You know, and something like, if I'm not wrong, I guess I am not, quite a preventive clinical eye in these patients, sir, in order to manage them, to avoid getting to the slap point in the future. This is something that we really have to understand. And we are talking about clinical analysis, very good eye, and then managing them properly. I always knew that conservative management in these patients has a big role, and it's everything about scapular enhancement. We know that for sure. But my question is, when we come to the idea, when conservative management fails, and when we come to surgery, I would say that nowadays I would feel, I don't deal with thrower sirs, but I would feel quite, and I've been discussing this here in Brazil for many years, I would feel quite uncomfortable of fixing a slap because everything can come back again because of micro trauma, because of pubic and scapular instability over time, even after physio, blah, blah, blah. So I would go straight to a tenodesis, and that is quite clear in my mind. I have operated 6 or 7, maybe 8 traumatic slaps with well-defined trauma here, and I have only been doing tenodesis, and so far so good. But they fall from bicycles or skateboards. They are not throwers. So having said that, sir, what do you think about a tenodesis? It doesn't matter where in these patients. Does it change the biomechanics of the shoulder, leading to loss of performance when they come back to throwing again? I guess that this is a 1 million question, sir.
Yeah, but I think
Dr. Swarnendu.
The question is that whether in the throwers you can still do the subpectoral tenodesis. I think these guys are really young. These guys are really young, and the problem is that it is very difficult. We don't get that your tight sort of biceps lesion, like where the biceps is completely been frayed. It is only been detached from your supraglottal tubercle, and there is a complexity of the tear extending either in the front or the back, or sometimes with the front and back. So you can repair those, and you can have the best possible outcome with those, because if you just sacrifice that part of the dynamics of the intra-articular part, what the God has given to stabilize the humeral head, to get back this sort of external rotation and the abduction and 90 degree of this throwing the cocking phase, then they will lose that. They will probably have that. They will probably have that power of the biceps, but the whole biomechanics will change. And it is not the question of fixing the biceps only. It is also the capsule because of the micro trauma. So go in, see the biceps, whether if it is the best, if you can fix that biceps intra-articularly without over tightening that biceps with the capsular lesion, probably he will get back to the same level of sports, rather than doing a biceps tenodesis in these young people at the subpectoral region.
Yes, I really want to listen to you guys, but before Dr. Rajkumar speaks, and I want to listen to Dr. Anand too, I have no idea, but I'm asking, is there any paper giving us the information that a subpec tenodesis can diminish the performance in the throwing shoulder? I would be delighted to listen, because I don't have this information. And a super biceps killer, you know that I am, sir. I have difficulty to see slap being fixed, but I don't deal with these patients, and we have to think about the whole biomechanics of the shoulder. But coming again to the question, if there is any publication or any data about loss of performance in the throwing shoulder with a biceps tenodesis, I would like to listen Dr. Rajkumar and Dr. Anand, please.
I wanted to comment on the thrower, because we see a lot of the high-end baseball pitchers in America. And it's very difficult, as we were saying, any type of surgery on these high-level professional pitchers to get them back to normal performance. And a slap repair is very difficult for them to get back to the normal mechanics, speed, and velocity. They may get pain relief, but they always end up being a little stiffer. They lose some rotation. I personally would perform a tenodesis, I think, in my overhead athletes, maybe not pitchers, but soccer players, throw-ins, things like that, javelin. They've done well with the tenodesis. I just think the high-level thrower that needs that hyper-external rotation, cocking, follow-through is difficult with a slap repair. It's the best we can to get them back to normal pitching. Thank you.
So Anand, I had difficulty to listen to you. But I'm going to ask you again. if you are thinking about, I would say, United States or a basketball player or a volleyball, but let's think about basket because it's so usual in the United States. So you have a 40-year-old man with a pasta lesion because he's playing since he was a kid. And now you fix the pasta lesion and you do a big or a smaller acromioplasty. The biceps was looking bad and you did a subpec tenodesis. I have done this here many times. They come back to, I would say, to basketball quite nicely. I don't see problems in that. Do you have the same experience with subpec tenodesis? I don't see problems in that.
Basketball is fine, but and those kind of lower level, shooting football players, throw is okay, but the high level pitching is difficult for me.
Okay, good. Dr. Rajkumar, you want to say something because you are going to talk about this topic, sir.
I must actually say a good presentation to Dr. Samanta.
Thank you.
And it's a good topic to discuss where, why the biceps pathology comes and how they will perform once you do a subpec tenodesis. Having said that, the funnel concept, as Dr. Samanta was speaking, that is the final end point of a throwing athlete. Actually, the entire force of the throwing athlete is generated from his legs, moves on to his core, and then comes through the funnel, that is the upper limb. So having said that, there are studies showing that if you work only on the legs of the patient to build the power and strength, the output through the funnel is only 7%. If you work on the legs and if you work on the core, and then the output through the funnel, that is the upper limb, will be 15%. That is nearly double. So it is not only that we do something on the arm and he is not performing, it is not like that. We need to work on the entire structure of the human body, and we need to bring into account the genetic chain that helps the part of the body to function.
Yes.
Having said that, there are clinical tests which we need to do before we finally say that the problem is because of the slap. And it was nice on part of Dr. Samanta to show us that, we have to rule out scapular dyskinesia before we touch the pathology in the shoulder if we are not clear. And I'm very sure there will be many instances in our initial practice where we would have done a procedure in the shoulder to find nothing. And actually when we reflect on what we have to see, there could have been a scapular dyskinesia, which might have been the cause for shoulder pathology. This is what I have to say at this juncture. Thank you.
No, definitely. There is a big hole of conservative management and on preventive management, because as you have mentioned, sir, and Dr. Swarnendu, you have to think about the legs, you have to think about the core, you have to think about the trunk and all of these things. And this comes to the beautiful, I would say, the beautiful word of scapular dyskinesia described by Ben Kibler and all of this stuff. So I know that Dr. Daniel, he understands a lot about scapular dyskinesia. I have seen some webinars of him about that. So any comments, Daniel, about scapular dyskinesia? How do you manage that? This is so important for juniors. And I would say as a daily practice and something special or not to add in these more high-level athletes? Daniel.
Well, first of all, a really great lecture by Dr. Samanta. I think that he stressed a very important point. One thing is to be a biceps killer, and another thing is to be a serial killer. We must choose those patients that really need to be killed, and not to kill everyone. And I think, again, we see that the function of the biceps is not only vestigial. Perhaps it is vestigial for a 60 or a 70 years old person, but as Dr. Samanta nicely has shown, in some patients, it is very important. Another great point that Dr. Murthi said, is that we must be humble. And most of our patients, especially athletes, are coming to us with an altered cinematics or altered biomechanics of their shoulders. And we try to reduce that alteration, but they are not reset in most of the cases to a completely normal shoulder. And so we must realize that we have a responsibility, and every procedure we do in our patients will have a good side and a bad side, you know?
Sure.
So I think that it is very important to stress the role of the scapula, to check the patient from the back. And sometimes it is difficult to know what was first, the scapula or the other pathology like the biceps or the rotator cuff. But for sure, we can work on the scapula. In fact, it was Rogut who, when teaching the patients the different home-based exercises, was stressing the role of the muscles that balance the scapula. And we always include that in the rehab program, just as the only treatment or as a postoperative treatment. We must always check the scapula and work on the scapula stabilizers. So I think we are getting very interesting concepts with the discussion and with the lectures we are receiving.
No, definitely. Yes, I just would like to highlight that enhancing scapular kinesia, okay, enhancing scapular kinesia and trying to achieve what physiotherapists call scapular symmetry is a key point in all of the cases we manage in the office, in all of the cases, and especially in these cases. So we cannot forget that many times subacromial pain is just, especially in young patients, a consequence of scapular asymmetry. We must never forget these points, never. But the thing is, in this case, it's very, very important. And even as Dr. Swarnendu has mentioned, even after surgery, without proper rehab, they will never come to throwing again, never, yeah? And having said that, I wanna listen to Dr. Swarnendu, please, about not only post-op management, but preventive scapular enhancing. I think that this is important. If you can say something about this, something preventive, Dr. Swarnendu.
Sergio, you have touched a very, very important part of the story, is that even the subacromial pain might be because of the scapula. So this is for the juniors, those who don't understand the scapular mechanics. You see, if the scapula is not been in proper place with the thorax, the scapula moves in a forward direction. And suppose it is like this, it stoops forward. So now your rotator cuff is going to impinge on that. So if you just stabilize the scapula on the back of your thorax, so the space between the scapula and your rotator cuff increases. So your impingement goes off. So this is the beauty of the scapular retraction test.
Beauty.
So if you, so your scapula, if it stoops forward, there is a less space to rotator cuff to travel. So if you just put one hand on the scapula and now you ask the patient to abduct or forward flex, his pain goes off. You know this is because of your scapular malposition. So this is a very, very beautiful and important test. If you learn this from this webinar, I think 50% of your things have been done for today.
Definitely, yes. This is so important. This is, just a second, Anand. We have to think about this as the scapular stabilizing test or the Kibler test. This is so important. When you put one hand in the chest, the other, you stabilize the scapula, and you ask the patient to elevate in the plane of the scapula, and the patient says to you, oh, my pain has gone away. This is a diagnostic test. It works so much. This is half of the value of this webinar to pass this idea to the juniors, which has completely nothing to do with surgery. And Dr. Daniel, he agrees with me, just with clinics. And I'm very happy if this message is passed to the juniors to understand the scapular stabilizing test. This is gonna make you avoid a lot of not necessary procedures. This is important, and Dr. Anand wants to say something.
I think Rajkumar
agree with
No,
I completely agree with
just
what
a
you
second.
said.
You can speak, Anand.
The scapular stabilization test is so important. The second test is also checking the posterior capsule. These patients with tremendous internal rotation deficit will get a secondary impingement. And simple treatment with capsular stretching, sleeper stretch, posterior capsule stretching, their subacromial pain will disappear in 2 weeks. And instead of doing a decompression or a acromioplasty, simple treatment.
Super. And the right plan and non-invasive. You are not invading the patient unnecessarily. This is so important. Dr. Rajkumar, you want to say something about it?
I agree with Dr. Anand and Dr. Daniel and all other panelists here that you need to stretch the capsule. That is good to exclude the cause for the pain. That is a very important point that if anybody who is listening to this webinar should take home. Having said that,
sure,
we have seen Dr. Samanta showing us a slab tear that is being repaired. If I may be allowed to ask to the panelists here, if you see a slab tear when you scope, what would be your limitation or high point to say that you are going to repair this slab, or you are going to manage it conservatively, even though you are seeing it on scopy? And what would be your portals of doing a slab repair? Choice of portals of the posterior suture slab that you see.
Dr. Daniel, anything to add in this beautiful discussion on understanding the importance of scapula in secondary subacromial pain? I want to talk a little bit more about that because I want to hammer this idea in the heads of the juniors. Dr. Daniel.
Someone has said that the scapula is the tray that put the shoulder in the space, in different situations, in different positions. So it's the basement for the function of the shoulder. So I think that it is key to work on it. We should be ashamed that for many years we did not put in importance the role of the scapula as it is now.
Sure.
Dr. Ben Kibler has given all of us really a very good service discussing and enlightening us about the role of the scapula. So I think it is very important to work on it. There are 17 muscles that are in charge of the scapular balance.
Yes.
And we must work on that. We must consider that. I am thinking that with this great panel that we have, we should, I can get in touch with him, we should include for a next webinar, Dr. Kibler, and have a discussion just
if
about
possible, that would be brilliant.
Because,
You'll be delighted to know that when I was the secretary in this time, the Indian Arthroscopy Society, we had the live webinar with Ben Kibler himself just few months back with him. So it's a great idea from here.
If you can ask him, I don't have the access, but that would be brilliant to have this guy here.
And I will talk to him, no problem.
Please, and I would like, just before we move to Dr. Rajkumar lecture, I would like to give a concept to the juniors that this is what we are talking about. So this is the shoulder, okay? And here we see the tip of the acromion. And if we think about the Bigliani classification, you would think about the outlet impingement, the typical outlet impingement. But when we are talking about scapular dyskinesia, we are talking about a concept which is non-outlet impingement. This is not what I think, it's written in many books. So we are having non-outlet impingement because of scapular dyskinesia, and this is something that we must rule out. Just something as a curiosity to open the minds of the juniors. Are there on the scapula other non-functional but anatomical causes of non-outlet impingement in the shoulder? Yes, we have two. Elastofibroma dorsi, those big soft tissue tumors that they alter the biomechanics of the scapula. The pain is here, the tumor is here. You take out the tumor, the soft tissue. I have taken out 4 or 5 in my life. And the other one, which I have seen 2 in my life, is scapular osteochondroma, which alters the balance of the scapula. And then you operate, you take out the scapular osteochondroma, and pain in the subacromial area, they disappear. But anatomical problems on the scapular, they are very, very infrequent. The vast majority of them, they are functional. And as long as you manage them, obviously, non-operatively, as we are all saying, many surgeries, many unnecessary subacromial surgeries will be avoided. This is very important. I guess you fully agree with this, but Anand, any comment final on this scapular stuff to avoid unnecessary surgeries before Dr. Rajkumar's presentation, sir?
The important thing when juniors are training is to always start with the examination from the back. You have to look at the scapular tract. You have to look how the scapula tracks. If you examine them closed, if you're unable to examine how the scapula tracks on the thorax, you'll make a lot of misdiagnoses on instability or primary impingement.
Sure.
Also atrophy, you can see serratus palsy, things like that, and people get operated on for instability. So always examine patients from the back.
Sure, that's a message that is half of the importance of this webinar. So having said that, now let's come a little bit more to surgical stuff and physiopathology. Dr. Rajkumar, can you start your presentation, sir?
Can you see my screen, Sergio?
Yes.
And am I audible?
Yes, you are audible.
Yes, you can start.
Well, thank you, team Sergio and OrthoTV and Dr. Daniel Moya and Dr. Anand, Murthi and Samanta, my co-panelists. It was a pleasure listening to your lectures and having given me this time to share my talk on management of biceps tendon pathology options and technique. I am from St. John's Medical College and Hospital, Bangalore, which is in south of India. And Bangalore, as you all know, is the capital town of IT in the country. And we are placed very close to the IT hub in Bangalore. And I welcome all panelists to visit our town and be a part of it whenever the COVID situation permits. Having said that, let me proceed. This will be the layout of my talk, as Anand has alluded earlier also. I'll talk briefly on the anatomy function. There may be an overlap between my presentation and Anand's presentation as we discussed in the beginning. but let's take it from here and see how best we can, supplement whatever we have spoken so far. Pathology, diagnosis, treatment, and our technique of managing biceps pathology. If we have to recap an anatomy in itself, we see that the biceps originates at the top of the shoulder. Most of its attachment, that is 50% of attachment, is to the posterior labrum. We have been taught that most of it attaches to the superior glenoid tubercle, but in fact, it is only 20%. The rest it shares with the labrum. Its smaller brother, we call it as the short head of the biceps, originates as a conjoint tendon from coropod process. Now, why everybody wants to go and kill a biceps? Probably is because of its rich sympathetic nerve supply and substance P and calcitonin that is present, and it is related to their genes. We do have a lot of this overlap of sympathetic nerves inside the biceps tendon, and that is the reason it is called as a pain generator. However, the biceps is dynamic structure which is kept in place by the deep groove that is there in the proximal humerus, surrounded by a nice anatomy that God has created around the bicep to keep it in place, especially the superior glenohumeral ligament, the coracohumeral ligament in the blue color, the upper insertion of the subscapularis, and the anterior superior portion of the supraspinatus. They do share the attachment there with the biceps tendon. The transverse ligament in itself will hold the biceps in place. So with all this anatomy around there, why we think that biceps will cause a problem to us? Dr. Anand has nicely alluded to the function of the biceps tendon. Though it is a gray area, there are stalwarts who have gone back and forth to say that biceps has got a function. Some have gone and said that biceps doesn't have any function. So if you can see here, biceps is thought to be a humeral head depressor. It also might help in some amount of external rotation. But and when we load the biceps, the anterior superior migration of the head of the humerus in a situation where there is a massive cuff tear is decreased. It also provides some amount of stability for luxation of the shoulder when the shoulder is in 90 degree of abduction. With all these functions attached to it, still we go on and say, yes, if there is a problem in the shoulder and we see a problem in the biceps, we kill it. Should we do it? Is a matter of debate. There is a nice topographic classification given by Hetman et al. You can see that he classifies into 4 zones based on where the origin of the problem can be. Lesion of the long head of the biceps in origin 1, that we call it as zone 1, is basically because of slap tears. In the supratubercular portion, which is the intra-articular portion of the biceps tendon, it can be because of tendinosis or partial cuff tears. When we come further down, we can see that in the sulcus or in the bicipital groove, which is zone 3, there can be subluxation or posterior superior cuff tear shared by the subscapularis tear as well. And below the groove, we call it as zone 4. It is usually the problem of the tendon and muscle junction. So if we classify them in this way, then we will be able to exclude from where the problem is arising in the biceps. There are 3 zones starting from the intertubercular sulcus, as also described by Taylor and his team in this nice dissection of the cadaver. The zone 1 is in the intertubercular. Zone 2 is between the intertubercular and the superior border of the subpect. And also zone 3 is below the bicep, below the subpect. So the problem in the biceps can not only be intra-articular, it can also be extra-articular, which is a point that we all should understand and take home from here. Pathology is well described by Dr. Anand. I will not spend much time on this, but we are all worried about the Pully lesions and its association with cuff tear. That is a key point that we need to keep in mind, because biceps problem doesn't occur in isolation. This is the classification which I picked up from Dr. Anand Murthi in the earlier period of my learning. And it's a very nice classification. I urge all the viewers to take a copy of this present paper and go through it, and which will help you actually in managing the problems with biceps. On clinical examination, as we were discussing in the beginning of the webinar here, it is important for us to find out clinically where exactly is the problem in the biceps, whether it is localized, it is radiating, or it is coming from outside the biceps pathology, or is it just a dyskinesia of the shoulder as we were discussing a few minutes before. However, there will be some indirect signs to say that biceps could be a pathology, like for example, a loss of terminal forward flexion could be due to an hourglass long head of the biceps deformity, which is classically described by Pascal Bolo in his article. Also, a loss of internal rotation in some situations along with the proximal subscapulary stare, which is called as the lag sign, could be an indirect sign to say that there will be a biceps pathology. Keeping in mind a thorough clinical examination, we move on for the diagnostic tools that help us to find out what part of the biceps is involved. X-rays, however, are not much helpful except in areas where there is irregularity in the area of the tuberosity. CT arthrogram is also helpful. MR arthrogram especially is helpful to know the entire morphology and the instability and the position of the biceps. Dr. Sergio was describing along with Dr. Moya about the dynamic instability that we need to pick up as a key tool in our day-to-day practice. If we have hands-on using an ultrasound in our daycare clinic, it will be nice to pick up these pathologies. However, arthroscopy is the key to diagnose biceps pathology. Now, why we are worried about, preserving the biceps or, using biceps in a way that we use day in, day out. Whether you are a model of great stature or you are a muscular guy, everybody would want to flaunt their biceps. And decision-making on the biceps entirely depends on age of the patient, the activity of the patient, its associated pathology. If the patient we treat is he able to comply with the treatment, and will he be accessible for physio, or has he exhausted all methods of physiotherapy and intra-articular injections that have not helped the patient. Appearance of the biceps is also key for some patients. That should be kept in mind, not to do away with the biceps just like that. Coming to the principle of managing a biceps pathology, what if the biceps is involved in less than 25% of the cases? And it is a normal biceps, leave it alone, or a skillful negligence should be the way to go. If there is involvement of biceps in 25 to 50% of the cases, and if the age of the patient is more than 55 years, patient is less active and he has got a cuff tear and is complying with the treatment, tenotomy should be an option. Tenodesis for less than 55 years of patient should be an option of treatment. But if the lesion involves more than 50% of the biceps, and if he is less than 55 years, active still, tenodesis still can be chosen. More than 55 years, he's got a sedentary lifestyle, tenotomy should be the option of management. So there are various ways to treat a problem. There is no one way, but the pathology and all other factors that influence management of the problem should be taken into consideration. Now, if you have to go through literature, what has tenotomy to say? Tenotomy gives us excellent results, as my previous speakers have spoken. It is a quick method which has got great advantage, simple and easy to rehab, and if required, we can convert later into biceps tenodesis if there is cramping and deformity and weakness. However, there is a nice technique described by Bradbury et al. To avoid this cramping situation You can do a fish tailing of the biceps while you are doing your tenotomy so that the tail of the fish locks in the transverse humeral ligament. When we have to do tenodesis, there are many things that cross our mind. Should we do it in the groove? Should we transfer the long head of the biceps to the coracoid process? Or should we do a keyhole tenodesis, open or arthroscopic? What is the advantage of doing a tenodesis? It gives a secure fixation. Deformity, especially the popoid deformity, is less. And generally, we need good power to function. However, difficulties in doing such a procedure, a longer rehab, and sometimes problems because of the hardware and neurovascular injuries and re-tear of the biceps are known to occur. So these are the points that we need to remember and then proceed to do tenodesis. Tenodesis can be done intra-articularly in the groove and as well as in subpectoral area. The type of tenodesis can be a soft tissue tenodesis, either by doing a tunnel or a keyhole or using an anchor or using interferential screw fixation are the methods to do tenodesis. Intra-articular tenodesis is quite easy because we see while we are doing a procedure intra-articularly and we can fix the biceps to the rotator interval or the transverse ligament. Having said that, sometimes these can fail and give rise to secondary problems of pain in the patient. Tenodesis in the groove is done generally in association with the rotator cuff tear and should not be done in isolation because they tend to fail when we do it in isolation, according to Gartzman and his colleagues. Subpec tenodesis is nicely described by Dr. Anand Murthi in his presentation at the beginning of the webinar here. This provides great mechanical strength to the individual who has undergone this procedure, and interferential screw fixation has and its usage in doing subpec tenodesis has been thought to give great results and have great strength and pull-out strength to the fixation. Also, if you can see here, cyclic loading has been evaluated using an interferential screw, which has found to be stronger, and it takes more load, and there is least displacement of the biceps tendon when interferential screw is used. Having said that, we come to our technique of arthroscopic keyhole biceps tenodesis. We have just extrapolated Froimson and whole technique to an arthroscopic procedure. Though it is technically demanding as few would think, it is quick and it will give us encouraging results when we do such a procedure. We generally measure the intra-articular length of the biceps. We choose the bicipital groove as the point of fixation for us because it is a wider area. The bone is strongest in that area and less chances of fracture. We generally use 3 portals to have access to this proximal part of the humerus. Long head of the biceps is doubled to resemble a button, and which helps us to lock it in the keyhole that we create. And the self-locking mechanism of the biceps into the keyhole itself without an hardware, as everybody was discussing about the cost of a keyhole tenodesis or the cost of a biceps tenodesis would be negated. And this is very cost effective and useful in areas where there is challenge of finance in doing a surgical procedure. This is how we do it. We retrieve the biceps tendon outside the shoulder. We resect the part of the biceps that is measured intra-articularly. We impale it and then we suture it over itself to create a button of sort. General size that is measured is between 6 to 7 millimeters. We now clear the soft tissue in the groove to may have an access to the intertubercular area. You can see the subpec coming, pectoralis major insertion coming in view there. We use the ACL jig and the bead pin to find the spot of sweet spot that we want in the tubercular area to drill a hole. And we first drill it with a 7mm drill. We use ACL offset guide to drill another K-wire in front of the hole that is drilled. Then we use the reamers to drill up to around 25 to 30 millimeter. The bony bridge between the two K-wires is now excised with the help of ronges that are generally used for spine surgeries in this fashion. And the keyhole is created for you for weaving. Once that is done, the biceps tendon is railroaded through a pull-through suture in this fashion. And it is helped onto the keyhole with the help of suture retriever. And once it is done, the biceps is locked into the groove and then the suture can be pulled out from behind. This is a very simple technique and you can see that the biceps is locked there and it doesn't move anywhere. Now we have presented our initial technique in this journal of orthopedic surgery. I urge the viewers to get a copy of this to help them do this procedure and practice in every day. The initial results of this technique were published in the Journal of Techniques of Shoulder and Elbow Surgery, and we are very happy to share this wonderful results that this keyhole technique gives. Also, there were questions as we progressed in our science of understanding how best the keyhole technique can be made foolproof or where people can adopt it to practice. There were concerns of cramping or the biceps tendon getting dislodged from the keyhole that we created. We went ahead and did what is called as stapling of the biceps as a marker so that to see how many of the biceps tendon really dislodged from the keyhole that we created. You can see in this representative image that there is a possibility that some amount of biceps can still dislodge if you have not locked it properly, or if there is a mismatch between the button that we have created and the diameter of the tunnel that we have, or in some areas if you have fixed it in an overtly tight position. Having said that, even if it dislodges, there are situations wherein the patient can present just with the Popeye deformity and not much of functional disability that they can have, as literatures in the past have shown that the results of either doing a tenodesis or any other sort of method of doing a tenotomy, the results are similar as of now. We went on further to assess the strength of fixation and compared it with all the standard methods that are available. And one standard method that everybody practices fixing a biceps for tenodesis is usage of an interferential screw. And in our practice, when we did clinical and radiological evaluation along with a marker study to find out whether interferential screw or keyhole tenodesis is superior, we did not find much difference between both, and we found that both techniques give equal results. And in fact, in some situation, keyhole tenodesis is less forgiving than the interferential screw fixation. Also, an extra-articular tenodesis of the biceps can be done, and it can be fixed to the conjoint tendon, as I told you in the beginning of the talk, as described by Verma and his colleagues. Having said that, what would be the scope of future for these kind of biceps pathology? There are paucity and of meaningful studies in describing what exactly has to be done, whether tenotomy or tenodesis. But with the advent of newer techniques like using biceps in itself as a tissue for superior capsular reconstruction and more understanding into the anatomy of the biceps being a depressor of the shoulder and also helping in providing some amount of stability to the shoulder, people would rethink of killing the biceps just like that. And I also would urge people to follow our technique of arthroscopic keyhole biceps tenodesis. And I must thank my mentor and teacher, Dr. Jean Canny, with whom I work, who helped us tremendously to improve this technique to this present stage. For this is an easy and a reproducible method. And I urge all the viewers to try it out in their clinical setting. And my message to all viewers would be, though biceps is a pathology in itself, it is not in isolation. Long head of the biceps pathology most often is diagnosed on arthroscopy. As Sergio and others on the panel were discussing, biceps lesion being associated with other cuff lesions or impingement, that is the point that everybody should note and should try to examine when they go through the clinical examination and arthroscopic examination of the shoulder. Although imaging studies are helpful, they are only a corroborative evidence for a shoulder problem. I would like to say in conclusion that learn one technique and practice what is best in your hands. I thank all the viewers for the patient listening, and now the paper is open for discussion and questions. Thank you very much.
Thank you, sir. Thank you. You see, another beautiful presentation. I would like to make some comments before we discuss again to the juniors. It's very important, as we keep on saying sometimes the same idea, because the juniors, they have to understand. So I'm going to state some messages before we start making the discussion. The thing is, as you have mentioned, Dr. Rajkumar, isolated biceps pathology is uncommon. And when it happens, it's much more common in young adults than in elders. This is something that we must understand. When we think about elders or middle-aged patients, biceps pathology is almost all of the times involved into some rotator cuff problems. And this is something that we see all of the times in the office. So, isolatedly is much more frequent. It's not so common, but it happens in the juniors, but not in the elders for sure. Another point that I think that we have to highlight is that the clinical examination is important. And as Dr. Swarnendu has mentioned, and as Dr. Anand has mentioned, the pain irradiates generally anterolaterally on the proximal 2/3. This is very important, and we have all of the tests. And I would like to make some comments before we talk about the techniques, sir, about instability that you have mentioned, Dr. Rajkumar, on the MRI. So when we think about the transverse cut on the MRI, we can see biceps medial subluxation, but it can happen in 3 ways. This is a message for the juniors. Firstly, it can happen anteriorly to subscap. And when it happens, you can infer the presence of a tear on the pulley, on the transverse ligament, but not a tear on the subscap. The second possibility is when the tendon on a transverse cut on the MRI is subluxating in between the subscap tendon. And on the third possibility, you have an intra-articular medial subluxation. And by that image, you can infer a full thickness tear of the subscap. These are some information that we can have when we see the MRI. But having said that, your technique is very interesting. And I guess that in spite of all of the learning curve, Dr. Rajkumar, one possibility for the juniors is to do this technique open with the same incision that Dr. Anand has shown. Yeah, I think that we have to think about not only people with good skills in arthroscopy like all of us, but many people who are interested in shoulder, and that would be a possibility to do your technique open with the incision that Dr. Anand has shown. What do you think about that, sir? I am always thinking about all of the people watching us. There are some people from Africa too, and they don't have all of the skills. I would like you to comment on that, and then Dr. Anand. You know, I know it's beautiful arthroscopically, but the learning curve is very high. So have you done this in open fashion, Dr. Rajkumar? I guess it's a relevant question.
Yes, it's a nice question, because as I put it, there is a big learning curve in doing it arthroscopically.
Very big.
Once you finish your diagnostic round or you see the cuff and you finish with your cuff pathology. You can tag the biceps as shown earlier by Dr. Anand Murthi and bring it out of the shoulder. And then you can make an incision in front of your shoulder, clean all the tissue that is there inside the groove, which can be a pain generator as well. Clean the soft tissues there, clean the bursa that is there in front of your eyes. And then you can do an open subtract tenodesis in a very nice way as we have described. Having said that, we should be also mindful of the axillary nerve which comes posteriorly here.
Sure.
In our cadaveric paper, we have described and we have shown that the technique that we do in the intertubercular groove does not cause any damage to the axillary nerve which comes posteriorly. When we, in our presentation, you must have seen that the K-wire came from the front to the back in this fashion. And you must be wondering in your head that, you know, and the axillary nerve could have been taken down. So far in our series, you have found only one case of an axillary nerve being impaled by the guide pin that exits in such a fashion posteriorly. And if you do it in a way that we have described, going it more little distally and keeping using the jig which we have described in our cadaver paper, you will be away from problems. And yes, open surgery is an option, as also shown by Dr. Anand Murthi in his subtract tenodesis. Open procedures can still be done. We should not go with an idea that only arthroscopy is the way to do a tenodesis of the biceps.
Sure.
Thank you.
Sure. I have a question about the position of the pin, but, and I'm going to tell you my experience using the J.P. Warner technique. But before that, I'm always thinking about the juniors. Dr. Anand, doing the technique of Dr. Rajkumar in open fashion, that would be a good solution in terms of effectiveness and costs. Do you agree with me?
Yeah, I mean, it was a very beautiful technique. And I think arthroscopically, as long as you're above the pedal, the guide wire should be really safe from the axillary nerve. I think that cadaveric study has been shown that's a really nice way to do that. And I think doing it open is similar. You know, it's more dissection, obviously, larger incision, but I think the keyhole technique is inexpensive, it's efficient, it's our mechanical study. We can see which one's strong or as strong, the keyhole versus, you know, sort of button fixation or anchor fixation, and we can prove that they're equivalent and cost effective. Thank you.
Sure. And one thing that I want to ask Dr. Rajkumar and any other who can tell me, I use it to do the same technique, Dr. Rajkumar, with the spin, the J.P. Warner technique with an interference screw, one screw. But I was always so afraid of the axillary nerve posteriorly, and we cannot forget that we are not in the middle of the arm, we are in the upper third, but there is a guy passing posteriorly, which is called the radial nerve. It's there, we know it's there. So, and hopefully, thanks God, I never had any problems. But in my opinion, if you see postoperatively a radial nerve problem and or an axillary nerve problem, the only solution for that would be to pray and to wait. Yeah, because that would be a desperate. I would be in desperate. So the only solution for this problem, I'm very serious, I'm making a joke, but very serious, is to avoid that to happen. I'm absolutely sure you agree with me. So just before you speak, sir, I tried to learn in many articles that the best position for the pin to go out would be more laterally. Yeah, you enter more anteromedially and you would out more posterolaterally. Am I right? Am I not right? What are the tips to avoid the nerves? And what was, Dr. Rajkumar, I'm very curious, thanks the case was not mine, allow me to comment, but what was the clinical picture of that patient with the axillary nerve palsy? And what was the final outcome? This is something we would really like to know. Dr. Rajkumar.
The position of doing a biceps tenodesis, which is keyhole, is after completion of your rotator cuff repair, yes, or any other associated pathology there. We generally operate in lateral decubitus position. We completely release the patient's traction. There is no traction whatsoever on the hand. The hand lies on the side in this fashion.
Okay.
And then we go in the axis of the biceps, and then we debride the intertubercular sulcus by the 3 portals that were described in our paper. And as you rightly said, your exit should be more lateral, not posterior. And we try to be like that from front to the lateral part in that fashion.
Sure.
Sometimes inadvertently, it might come to be more posterior. In such a scenario, as you said, yes, we have to pray. Having said that,
yes, we have to pray too much. Yeah.
Having said that, we should not forget to go back and examine the patient post-op, check thoroughly what has happened to the patient, check his power in the deltoid, the sensation. If given a choice, which nerve injury do you want? Axillary nerve is a mixed nerve. The recovery rates are less good. But if you have a choice of having a radial nerve impalement, that would be better, because once your pin comes off, since you're praying hard, there is a possibility that the radial nerve can recover.
Yes, I know that. And, I know that, you know, and the thing is, we have to remind the juniors, okay, this is for general orthopedics, that whenever you have a nerve problem, you have to wait at least 30 to 35 days before doing an electroneuromyography because of a phenomena called Valerian
degeneration.
Excuse me?
Degeneration.
Degeneration, yes, yes. And besides that, the electroneuromyographyst must be a very good guy knowing all of the clinical history. You know, it's almost a craft work exam. So we must have, but you know, but the key is to avoid that for sure. The key is to avoid that. But having said that, Dr. Swarnendu, you do so much shoulder arthroscopy. Have you done this technique of Dr. Rajkumar? Any thoughts? Have you not done yet? We have many ways to skin the cat, and the cat is the biceps. But any thoughts on this technique, sir?
No, I have seen this. My friend Dr. Rajkumar is doing since long, and I have learned this technique. But frankly speaking, I have never done this personally in my clinical practice, because I do with because I have always the problem, because the fear of the nerve is always there, as we are discussing.
Sure.
And thing is that, and I always do not the arthroscopic, because once I finish the cuff job, I just do the small incision, take the biceps off, and just put one screw over there, because this takes very little time. And you see the chance of the main thing is that the chance of a fracture, which is a real concern for this, for our guys, because if it is a hard bone, if you drill and put anything hard over there, you can have a pathological fracture afterwards also. So you have to keep in mind, not the nerve also. You have to take care that if you are not banging something which is very hard in front.
Yeah, before Dr. Rajkumar speaks, the thing is, I am always in the fear of a fracture over there. And for those who have experience like us, that bone is extremely hard in the subpec area. Is very, very hard. So an advantage of my technique with 2 holes is that you are passing the tendon through the tendon once again, and the cost is 0, is only one suture. But Dr. Rajkumar's idea would be much more safer in terms of a fracture in the future, because I am doing 2 screws, 2 holes, and he's doing 1. So that's something that I'm gonna think about a lot. But the thing is, I have another question to you, Dr. Swarnendu. because when I do this technique, I am always with a lot of fear of the swelling on the shoulder because of the cuff job. So I do this procedure, the subpack, in a very clear rationale. I do a 7-minute shoulder arthroscopy. I cut the insertion of the long head of the biceps, and then I stop the arthroscopy, and I do that in open fashion with a very dry shoulder. And then I close the subpack, and then I move to the cuff job. As I am understanding, sir, you do this in the end of the surgery, but I am always afraid that there would be so much swelling that it will turn the subpack mini open in a very difficult job. So your thoughts about that, and I want to listen to Dr. Anand. This is a very important question for the juniors, for the daily practice, sir. Dr. Swarnendu.
Yes, I think the main problem for this, when we start doing the arthroscopic job, the lot of fluid goes in, and
sure.
it at the end of the surgery, it doesn't look like a shoulder. It looks like
yes.
a watermelon.
A watermelon.
It looks like a watermelon. Okay.
Yes.
So gradually, once you learn how to reduce the fluid and how your fluid doesn't stay in the shoulder, because you are not doing here, it is not arthroscopy, it is endoscopy. So that's why this is of so much of fluid leakage in your rotator cuff. So once you learn how to reduce the fluid, and once you speed up every step, so then fluid extravasation is not that great. And at the end of the procedure, you can take off your subscap, your biceps.
Yeah.
But if you do your rotator cuff more than 2 hours, then it is very difficult to find something around the shoulder. So
extremely difficult, very difficult.
So I will rather recommend what my friend Sergio is telling, that if you find that it is difficult to find and dissect around the subpectoral region because of the swelling you apprehend at the end of your surgical time, that probably you can fix it before, because hardly it will take 5 minutes time rather than to struggle at the end.
Yes, and you know,
because already tired and OT is flooding with water. So then it is then it is difficult. So I think that is a good trick.
Yes, you know, I think that it's safer, in my opinion. We can do it in your way, but for the beginners or the juniors, I strongly recommend that to do it in my way, which is safer, is easier. You do a 5 minutes arthroscopic job, you cut the long head of the biceps, everything is very dry, there is no swelling, and you do the mini open, it's not difficult, and then you close it, and then you do the arthroscopy. That's safer, sir. I think that this is a message for the juniors. Having said that, Dr. Anand, well, I'm not sure if he's there.
No, he's not there, yeah.
I guess he's not here. Okay, but Daniel, I know you're a fan of open rotator cuff repair, but any thoughts, even in open surgery, about subpectoralis biceps tenodesis? Do you do this? If yes, when? I want to listen to you, Daniel.
Good. To begin, it's Anand back.
Oh, Anand, you are back now. You were off for some minutes. I'm not sure if you are listening to us. Yeah. You're back. So I have a question to you, but Dr. Daniel is going to speak first, and then I'm going to ask you, Dr. Daniel. I'm going to make the question again for Dr. Anand to listen. I was asking you about your huge experience with open cuff repair, and in that scenario, your thoughts about when and why and how to do a subpectoralis biceps tenodesis in your super experience with open cuff repair, sir.
Yes, I just want to begin saying that I, many years ago, performed several open keyhole tenodesis, and the results were really very good. I did not have problem with that, and for me, at least, I did not have many problems about chronic pain on the bicipital group after tenodesis. At least our experience is that we did not have that, you know. I think that, as Anand said, in athletes, subpectoral tenodesis is a good option. The type of patients I treat are mostly degenerative cases in patients over 60 years old. Yes, yeah, in older patients. So my more common indication is we perform an upper group tenodesis at this time, and we do not have problems with that. We used to make a mini open incision over the group some years ago, and my complications, because I don't want to say I do not have complications, but I have had pain in the bicipital group because I was too kind with the biceps, and I forgive the biceps sometimes, and I realized that was my mistake, that I should have proceed with the tenotomy.
But kill the biceps,
I in general do not have problems when performing the biceps tenotomy and tenodesis.
Yeah, and Anand, are you listening to me now? Yeah? Are you listening to me now?
I am.
Okay, good. So I want to do to you a last question, because this is for the juniors again. Oh, excuse me. I am here. Okay, so the thing is, I was discussing with Dr. Swarnendu that there are two ways of doing the mini open for the subpectoral tenodesis. The first one is in the end of the arthroscopy, and the second one is, as I do, you do a 5-minute job arthroscopically, you kill the biceps, the shoulder is very dry, and then Sergio, I stop the arthroscopy after 5 or 7 minutes, and I do the mini open with a very dry shoulder, very dry. And then I close it, and then I move to the arthroscopy because I don't have to worry about the swelling anymore. There is another way of doing this, which is the mini open in the end of the job after the cuff job, arthroscopically, of course. But then the shoulder would be more, I would say, insufflated, much more swelling, and that would bring some technical difficulties. So what I want to know, how do you do this? Like I do in the very beginning, after a 5-minute arthroscopic tenotomy, or in the end. And if you agree with me that for the juniors, doing as I do, 5 minutes tenotomy, stop arthroscopy, and then you do it with a dry shoulder, is much more safer than any other way. I want to pass this idea to the juniors. Dr. Swarnendu agrees with me. I guess you will agree, but I want to listen to your thoughts.
Yeah, I mean, I think if you see on initial inspection that it's going to be a large rotator cuff repair, then I think doing the tenodesis early is okay. If you're doing an hour long, you keep the pump pressure low, the fluid pressure low, you can usually find the inferior border of the pectoralis. And even with swelling, you can retract that with a Homan and see your bicipital groove. But if you're getting into the 2 hours, 2.5 hour cuff repair, I would consider doing the biceps early.
First,
Agreed.
Okay, lovely. And one thing that I would like to ask all of you guys before we finish, because this has been a game, I would like to listen to all of you, the 4 of you. This has been a game changer in my life in the last 5 years or 4 years, which is the use of tranexamic acid in my shoulder arthroscopies. This is something that a lot of people have been using in total hip replacements, total knee replacements, and I was listening to that, and some guys started to use that to use it here in my city, and I started to use tranexamic acid about 4 years ago, and now I am using in all my shoulder arthroscopies. The anesthetist injects it 20 minutes before the surgery, and the bleeding has been much less in my practice. So what are your thoughts about that? I have seen papers about the use of tranexamic acid in cuff arthroscopic surgery, but any thoughts about that? I want to listen to all of you, because if you are not using, my dear friends, I honestly suggest you will be mesmerized by how much less bleeding you can have. Dr. Swarnendu, any thoughts about this? Tranexamic acid?
I'm reading the papers. I have people are really using this tranexamic acid for their different surgeries, like your total hip, total knees, and all these open surgeries. I have never used any of my arthroscopic surgery, rather it be in hip or any other joint in like your elbow and ankle, whatever. But I have never, because of I've been lucky that my anesthetists are too good. They more or less provide the white sort of field. So I've never used
it. Good. Dr. Daniel, any thoughts about this? I'm just telling you because this has been helping me too much from the last 4 years.
Yes, here in Argentina, there is some experience with La Target procedure, but I personally have not used it yet.
Okay. Dr. Rajkumar?
My personal preference of using anything to reduce bleeding is only an adrenaline spiking the
saline.
And also working on pre-op on the patients to control their blood pressure and anxiety.
Sure.
Having an anesthetist as a good team member to help you do the procedure is a best option. Usage of tranexamic acid we are reading through, but in my practice, I have never used tranexamic acid for shoulder arthroscopy.
Lovely.
If it's helping you, I would love to try, and I'll get back to you on that in my next webinar.
I was listening to that from other shoulder guys in my city. It's a very big city, and I started to read something, and I have been using on a regular basis. And this is a very serious and humble comment. You will love to do this because this has been helping me too much, especially on small tears, a lot of bursal inflammation. It's a game changer, at least in my life. Anand, anything to say about the tranexamic acid in shoulder arthroscopy?
Yeah, I mean, first I use it on all open cases, arthroplasty. Makes a huge difference. And I routinely will use it in arthroscopy as well, especially in patients who have been on a blood thinner. And anytime intra-op that I get into bleeding, I'll add IV 1 gram of tranexamic acid also. And it just stops the bleeding instantaneously.
So as I am understanding you, Dr. Anand, you are using the tranexamic acid in your shoulder arthroscopies, yes?
Correct, as much as I can.
Oh, so good. So it's not only me. And do you think that if you think about your shoulder arthroscopies, I'm not talking about bank carts because the bleeding is very less, but I'm talking about rotator cuff problems, especially not in the articular part, but in the subacromial area and space. If you, Dr. Anand, if you think about the bleeding on your rotator cuff arthroscopies before the use of tranexamic acid and after, do you see a big difference?
It's a huge difference. Huge difference.
Lovely.
You'll have cases where even when you're doing a chromioplasty, it doesn't bleed, and so and you can work medially. You can do your medial releases without any bleeding at all. It's incredible.
Yes. So this is something that I am very happy to listen because it was not in the scope of the webinar, but I was thinking about this, and it keeps just I would say a recommendation, or I would not say that. I would say more humbly a humble but very serious suggestion, not to all of the panelists, but to all of the audience, to use tranexamic acid in your shoulder arthroscopies. It has been helping me too much, especially on the medial part of the subacromial area. in which you have to do all of the bursal releases and all of that big work, which especially in small tears in middle-aged patients, it bleeds a lot. And I've been talking to a lot of anesthetists. I just want to listen to the feedback of Dr. Anand concerning his anesthetists, because here in São Paulo, I have been talking to many anesthetists that they told me that the problem of tranexamic acid is to use it in very old patients. But now, even in patients 70 plus, I have been using them without any problems. So it's safer, it's safe even in elders. Do you have the same sensation, Dr. Anand? And what does your anesthetists say about the safety of tranexamic acid in elders, especially 70 plus rotator cuff patients?
Yeah, as long as they have not had a history of hypercoagulable disease,
sure,
or on any type of blood thinner concurrently, we use it all the time.
Sure, sure, yes, yes, yes. That's exactly what I hear. When you have a patient which has already had a heart attack, or when he has a stent in the heart, and then he used some blood thinners medication, then we have to take the, yes, and then the cardiologists, they ask us to take out the medication 5 days or 7 days before. In these cases, I would be quite afraid, but not in the others. So I would do just a suggestion for all of my friends. If you, Dr. Daniel, Dr. Swarnendu, Dr. Samanta, if 1 in 2 months, you can give me a feedback of eventual use of tranexamic acid in your shoulder arthroscopies, I would be delighted to listen, because I think this is it's a game changer. So having said,
many papers are coming on tranexamic acid used in this copy. So I will love to use in a few cases, also get back to you.
Lovely, lovely. So see, my friends, I just have to say thank you to all of you guys. We are reaching 2.5 hours, and generally this is the time. So it's a pleasure to have you all here. I just have to say thank you for Dr. Swarnendu, Dr. Rajkumar, Dr. Daniel, Dr. Anand. Dr. Anand, this is the first event you are here with us, but not the last. I'm gonna grasp you in wherever you are and bring you back, because this is something very important for us. We are thinking about doing something in the end of November. Soon I'm gonna come to all of the world with the data, the information in 1 or 2 weeks max. And I just wanna ask here publicly, because it's easier as we are all together, to Dr. Swarnendu and to Dr. Daniel, if they can really, as per their suggestions, talk to Dr. Ben Kibler quite soon, in a way that in 1 week, maybe I would say 2 weeks max, we can have a feedback from him to do something on scapular dyskinesia. That would be fantastic. And just to know that, Dr. Anand, if, by the way, I'm just thinking about now, if we can have Dr. Ben Kibler, maybe as you are in the United States, maybe if you know, Dr. Anand, a good physiotherapist to give us, I don't know, a nice lecture about scapular enhancement. I have some in Brazil, but they don't speak English well.
I have some great therapists. I have a great therapist to be willing to do that.
Okay, lovely. So then we can change things, and we would talk about, I would say, small tears of the cuff, but we can change things and do something beautiful about scapular dyskinesia. Dr. Daniel, I'm kindly ask you to help us and help me, because you know, Dr. Ben.
I have just written to Dr. Kibler, so we'll see. He always answers very quickly. So let's see. I wanted to have the answer before the ending of this meeting, but
yes,
I will, for sure, we will have an answer very soon. And if Dr. Samanta helped me,
I will just immediately write to him.
Okay, lovely. So my friends, thank you very much. Namaste. Dr. Ashok from OrthoTV. He's the boss. He's the big boss. He's got, I just want to know if you want to say something, Dr. Ashok. You know, it's a big achievement for me, not only to be putting everybody together, but we are getting into something that is very precious to me and which took me years to reach, which is the Indo-American shoulder world into United States. It took me a lot of time to reach these guys, and finally I'm there. So it's one more conquer, not to me, but for all of us. So I'm very happy about that. And I'm very happy that Dr. Anand is gonna come with us and help us with his physiotherapist friends and team. And to finish, Dr. Ashok, if you wanna say something, I am all ears, my friend.
Sure. No, I mean, it has been an excellent journey since last 1.5 years. And we have been doing these programs regularly and involving a lot of people across the globe. And like you said, getting into US, getting into Argentina, Brazil, even UK, India, of course. So we are getting towards a truly international platform and trying to bring different viewpoints together. That is what makes it more interesting. Listening to viewpoints from different countries on the same topic. We have seen this very, very frequently in the Shoulder Planet webinars. That for the same problem, we have so many different solutions from different parts of the world. And that's the most important point that I feel is about these webinars. So thanks a lot for your efforts.
Yes, so thanks everybody. As I always like to say, namaste, namaste, namaskar. And Dr. Anand, thank you very much for, I know you are in the middle of a journey, so sorry to your family, but thanks for your wife and kids that have been very understanding. Yeah?
Thank you.
Thank you very much.
Bye-bye.
Thank you. Have a good evening.